Distraction for spinal instability. So I think we need to define what type of instability. Historically, instability has been a contraindication. And the reason was, historically, the indication for traction was to provide mobility, especially large amounts of mobility by using very large forces. And that would be a contraindication to moving, especially acute injured tissue, as well as tissue that's already hypermobile. So spondylolisthesis, spondylolysis, for example, has been a contraindication. Now, if we consider today's technology, today's devices, so I've already outlined the fact that we can use very low energy densities, and I can actually start to apply tension to tissue even before I start to see large amounts of mobilization in the joint structures. So, in fact, when I first started with the newer tables and my different thought process, I actually had a basketball player, an American basketball player with spondylolisthesis and spondylolysis and 2 levels of disc herniation, and he was injured acutely. And so the idea was, well, if I don't want to pull him too hard, maybe I can pull him with much lower intensities and create a suppression in motor neuron excitability, which would further suppress his muscle spasm or hypertonicity. And in fact, when we do that, it actually creates immobilization, especially when you use static, which is the reason I choose to use static during those early stages of acute injury. So we can basically mimic some of the procedures that have been done in the past for post-surgical procedures, or one of our emergency splints we use for a fractured femur is a hair traction splint, and it's used to provide tension on the femur to decrease spasm for the hamstring muscles. And so it's a very, very similar concept, but understanding that we're not using really large forces, and that's why if we're using that approach to create actually an immobilization, a suppression in muscle spasm, we can actually treat spondylolisthesis and spondylolysis. Malcurari formation is another one where it's typically, in many patients, it's an incidental finding. They may have had it. They didn't know that they had it until they start experiencing some of their symptomatology. Now, the surgical procedure is actually a decompression procedure. So again, we're not trying to create large amounts of mobility in there, but in a lot of those patients, especially if they have a low-level malcurari formation, they can experience a lot of benefit and comfort. And certainly during the acute injury, and again, I treat a lot of acute injuries with spinal distraction immediately following an injury, as long as I rule out things like fracture, in other words, ruling out the contraindications that we shouldn't be treating with. Another question was clinical perception of spinal distraction versus the evidence in the United States. Really good question, and the difficulty that we're running into is the differences in research performed today versus 10 or 20 years ago. Healthcare policy has had a lot to do with dictating how some of the outpatient research is being done. I used the example earlier of the Julie Fritz study. So in 2007, they were treating patients initially 4 times a week. And then in the follow-up study, they were treating patients less than 1.5 times a week on average. And there was another paper by Ian Young and his group in the cervical spine. Very similar findings when they treated patients less than 2 times per week. And one of the things that we're seeing is that as commonplace in outpatient clinics, because reimbursement has been declining and the cost to the patient has been increasing. So they may have to pay out of pocket more and clinicians are trying to save patients money by telling them not to come in, or maybe only come in once or twice a week. And that decreases the dose response to the things that we're doing. And then, of course, when research is done by that method, it's published, and people read that, and they don't understand necessarily the statistical analysis that's showing that it's ineffective if you're going to treat at a low dose response versus it's completely ineffective. In other words, it hasn't changed. It's still effective when you use it appropriately, but if you're only going to treat patients less than 2 times per week, it's probably not going to be effective. And then there was a meta-analysis published back in 2013 by Wegner, and basically what they showed was even though they didn't add any more studies to the previous Cochrane review, they came up with a different analysis. And so again, that level of interpretation is misinforming people, and they're making that perception based on someone's interpretation of what they consider to be beneficial. Wegner is not a physical medicine practitioner. In fact, Wegner is an epidemiologist or a statistician and writes on physical medicine and breast milk and other various issues in health, and not understanding the clinical approach. And unfortunately, that type of information that gets out, it's perceived that way. So we're having some difficulties in our physical medicine world because people they're seeing that that type of research out there, when in fact it's not the complete understanding that they're missing, and as a result of that, we're seeing decline in the educational approaches as well. So we're seeing some changes, and it's not just with traction, it's actually in all physical agents, and it's related to the more recent research. And again, it's not wrong if you're only treating patients with that low level dose response, but people are interpreting that as an overall perspective of how things are actually working. The adjustments in the parameters and clinical practice and the evidence, and how are we determining the approaches that we're using? Well, I hope because there's the evidence-based approach, so clinical expertise, research, and patient preferences. And actually, the patient preferences component is fairly recent. A lot of people didn't take that as much into consideration. And what that means is, what does the patient want to do? What will they do? And how will they be compliant? And that's a big part moving forward, especially given the number of times that a patient may actually allow them to be treated. So I'd mentioned earlier, I wanted to, show a case to elicit this. So this is a case I consulted on. It's a 79-year-old male. He used to be a professional baseball player, and then he became a professional scout. So hopefully you can see this, but in essence, this patient has hardware that runs from his pelvis up to his lower thoracic spine, and that's the lateral view. And this is the anterior to posterior view, so you can get an idea that these are actually screwed into the pelvis itself and run up to the lower thoracic spine. This is the same patient, and this is the A to P cervical, so you can see that there's fusion from a good portion of a cervical spine down into the upper thoracic spine. So fortunately, and this is the lateral view, you can see that C1 and C2 are not fused. So basically the level of mobilities that this patient had were the upper cervical and his middle thoracics. Everything else was essentially fused, and as you could imagine, this patient's experiencing pain. And we don't have any specific guidelines on necessarily how to treat this patient. I'm a big fan of using spinal distraction. In fact, I use spinal distraction for every single spine patient, because I use spinal distraction as a form of mobilization, and I use an outcomes-based approach. So this patient doesn't fall within the clinical prediction rules or guidelines of what we've seen in some of the literature. So I have to use my clinical experience, but also, using the evidence biomechanically on what we could actually potentially do for this particular patient. And I'd mentioned this earlier with the question on the slump test. And so what we were able to do with this patient, and actually started experiencing positive outcomes even after the first visit. And we're not going to create mobility in segments that are already fused, but the spinal cord is not fused, the nerve roots are not fused, the muscle tissue is not fused. It's only the osseous structures. So we can create mobility in a lot of those other tissues by creating mobility in the parts of his body that actually can. So because of his fusion level, when we did lumbar traction on him, the mobility that would actually take place would be in his mid-thoracics. Okay, and so what that gets us is some mobility in the neural tissue, which is really important, but also in the muscle tissue and some of those segments that are being overstressed as a result of the changes in mechanics. So we use a component of the research evidence, and I have another example. So I had a patient come in last week, and she's 90 years old. She's actually very active. She swims every day. She walks approximately 4 kilometers every single day until she started experiencing neurological deficit approximately 2 months ago. And just because of her age, she was treated because of her age, not necessarily her particular outcome. So I'm the 4th practitioner that she's come to visit. And so the first thing that we did after treating her and managing her pain, like I said, I'm a fan of light therapy, in particular laser. And then we had her on decompression. Now this particular patient was experiencing too much pain to lay on the affected side, so this is an example of putting her on her unaffected side, and she could not lay prone and she could not lay supine. And so the idea was to create some mobilization. She was experiencing stenosis symptomatology. We didn't have an MRI on her, which was fine. We didn't have any neurological red flags that would lead us to believe that she was going to respond negatively. Decrease in disc space in the lower lumbar spine, and stenosis on the lateral canal. And just by opening up that lateral canal through the method of spinal distraction, she was able to experience a decrease in radicular pattern even during that particular first treatment. And now she's 3 treatments into it, and she's already had more of a positive response in the 3 treatments than she's had in the last several practitioners that she's seen, especially not having to use any medication to continue to work with her problem. Graduating the distraction and the intensity. So this is the approach that we take with regards to progression. Now the intensity that we start with is very, very low, but it always progresses. So the benefit of starting very, very low is it decreases my chances of over-treating patients. And so as long as a patient can get on the table and they're comfortable, and we don't increase their symptomatology, that's a good indication that they're going to be a candidate for this particular therapy. So if we think about what it really is, it's a form of long axis traction, just like we do in the extremities. It's a mobilization technique. And so there are very few conditions that wouldn't benefit from a mobilization technique, and that's a pretty good indicator that they're going to benefit from that if they're not a surgical candidate. In fact, I just had a recent meeting with a group of colleagues, and they're hopefully going to be publishing this data very soon. But they found acute patients, the larger volume the herniation was, the quicker the response and the better the response as a result of using spinal distraction at a very, very early stage when most of these patients would have been considered surgical candidates. So the progression is really based on outcomes. If we're getting a positive outcome, we don't change it. If they had an adverse reaction, and this is the other benefit again of using very low energy densities, is we rarely see adverse reactions. So that's our first goal when treating patients, is not to have an adverse reaction. And if there is an adverse reaction, then we look at the parameters that we set, and usually it's going to be a decrease in the intensity, and secondary would be a change in time. Progression is usually going to be when we do not see a positive outcome following 2 treatments sequential. And again, it's very unusual, but it's possible. But most patients will average the relative treatment effects will progress to somewhere between 50 and 85 pounds in the lumbar spine, and somewhere between 15 and 25 pounds in the cervical spine. So even though the starting points are very, very low, we do see a moderate increase in most every single patient, and that's very consistent with what would be considered to be therapeutic. But again, it's going to be based on the patient outcomes and where they're actually experiencing the benefit. So some patients respond more appropriately to lower energy densities and some with higher energy densities. I would rather add to it if we don't see a change than make a patient uncomfortable and have to eventually take that away. So we can possibly get over 100 pounds. And the reason for that is the patient may not be a disc candidate, and especially patients that have large amounts of degeneration, multiple levels, and are older in age, they're less likely to recover that space that has been decreased in between vertebral bodies. And so we will see progression, possibly over 100 pounds. It doesn't happen very often, and we find that less is actually going to be a potentially better outcome. So this is just the example of the disc herniation and the starting points for these folks. And it may be even lower if it's the first time that they come in. But what we get to accomplish from that is not creating an adverse response, and we can do it progressive. And the nice thing about that too is it shows progression over time, which may be beneficial in getting a third party pay for that. Influence of distraction on disc and surrounding material. Does it actually affect the disc? Well, that's what was shown consistently in many studies in both the cervical and the lumbar spine. So we can retract a nucleus, and there's many studies that show that. And then Dr. Pete Lallier is the physician that I recently worked with, and there's no association even with the size of the potential volume. So as long as there's no neurological red flags that say that we can't manage them conservatively, size doesn't even matter. In fact, if it's acute and it's of large size and single level, it tends to resorb much more quickly. The older the patient is, the less likely that they're going to experience an increase in disc height, which again sort of indicates that it's not just the treatment of the disc that's actually giving us that potential positive benefit. And I'm reminded of the study that's often reported in the meta-analyses and Cochrane reviews is a study in the mid-70s, and they weren't using MRIs but using very aggressive traction treatments with exercise therapy, and showing again on plain film radiography that there was no change in disc height following treatment, even though they had a very high success rate. And that's also very consistent. So what that tells us is that yes, we are definitely affecting the disc, but it's also telling us that that's not the resolution in all the cases. So other potential opportunities, and this is the Sari paper, and they've done this in both the lumbar as well as in the cervical, and showing the effectiveness on local surrounding muscle tissue. So even though it's very minute, we see small changes. So the actual separation between vertebrae in the lumbar spine, for example, and it's very similar in the cervical spine, is 2 to 5 millimeter change at each segment, and it's going to be dependent on the amount of intensity that they're being distracted with, but it's very minimal. So we're not really stretching a large amount of tissue. We're more applying stress to the tissue, but it's enough to see changes in cross-sectional area of the muscle that runs longitudinal to those particular segments, and that also includes the psoas muscle. So I'd mentioned earlier, one of the reasons I like to treat patients in that supine position is specifically because of this effect. Neurologically, we see a decrease in motor neuron excitability, and it affects local, so it affects the intrinsic muscles as well as the extrinsic muscles, and it also affects distal. So in the lumbar spine, it affects the sciatic and the posterior and the anterior structures, so it affects the femoral nerve and the sciatic nerve. So we see changes neurologically in the quadriceps and the hamstrings and so forth. And it's the same thing in the upper extremities where we also see that. So in other words, there's a large change in the neurological pattern. So many different structures that are going to be affected. And again, one of the main reasons that we see dramatic changes, even though we don't actually see complete resorption in a disc. Now, studies have shown that we can resorb. It does go into a disc, but in many cases it doesn't, especially if there are multiple levels, and that's why we don't see a change in disc height. That material actually gets resorbed. And hopefully what we can accomplish as a result of that is treating the patient by using posture and exercises to maintain good position and generate forces of posture and movement through the muscle tissue and less through the structural tissue, including the intervertebral discs. Also in the central and the lateral canal, and this is important too, because especially when we see multiple levels of degeneration, we also see buckling of the ligamentum flavum and the posterior longitudinal ligament, and it encroaches in that central canal. And so, we see immediate opening of upwards of 25% in the central and the lateral canal, which means that's why it's not unusual for patients to experience benefit by removing space-occupying lesions even during that immediate treatment. And so I think that's about it. Obrigado. I hope I said that right. But so there's my email, chrisproulx@gmail.com. You folks can have a copy of this presentation. I tried to keep it short. I was supposed to keep it to about an hour, but I think I went about 20 minutes over. We also have some more of those references in there, and again, that can be part of the presentation for you that you can get your hands on. I will send it electronically. But please do contact me if you have any questions, want to have any further discussion. Really encourage that. And I hope you enjoy the rest of your Congress. And happy treating patients. Take care.